Welcome everybody for this webinar. This is related to structured judgmental review process, which is a methodology for reviewing case notes for those patients who have died in acute hospital settings in UK.
It all kicked in when Stafford incident happened a few years ago. I think you might know the incident. It was a world-renowned problem, and after that there was some points to learn. And what actually they found was that things were not communicated properly to the higher people up on the like a consultant level, or maybe they were unaware what's happening on the ground level. So that's led to a huge inquiry, and it lasted many years. And that report actually concluded that we need to actually start a robust system where we can actually learn and immediately we can stop. So it's like a highway or highway of information from lower level, from nursing, from junior doctors to the higher levels. So after a long discussion, they came up with an idea that there should be something where we can actually learn things from people who died. So that was the link actually, which led to further system rehauling, and then all this discussion continued for a couple of years. And the National Mortality Case Review program, the main aim for this program is understanding and learning about problems and process in the healthcare associated with mortality, and also to share best practice. Yeah. So this is from Royal College of Physicians. So all slides are made by them. I have just added few and subtracted few of them over time. So originally we started in our hospital this training program in 2019, early 2019. So I was trained from the Royal College in 2018 as a first tier. So there was like a super trainers, which like a Professor Hutchison or Andrew Gibson. But super trainers are those ones who train people because they were not able to train everyone. So that was the main thing. So reviewers has to be trained. So this is a reviewer program. So the person who can review, we know we were reviewing pay, all our during our trainings, and even for years we all know how to review case notes. And basically you all know how to do root cause analysis. So it's a kind of root cause analysis thing, but this is a special program. There's a methodology involved in that. So what they did actually, they taken a few people from different regions. So I was trained there, and then I was appointed as a first tier trainer for Royal College of Physicians in our hospital. So I started training. So I had done like 120 people, consultants I have trained over. So these are risk management department group, hospital mortality group there. So I came in the patient safety a few years ago. So I started doing this one along with them because we did this face to face. Mostly face to face was more easier at that time. We did face to face, but then COVID hit us and we started doing. So basically, this program is to know and review the case notes and see whether the care was optimum for patient who had died in the hospital. So this program is only for those patients who had died in the hospital. It's not for those patients who died in the community.
Okay.
So that's one difference. And also it has not started in the children yet. Adult deaths happening in the hospital only. Now the judgmental review is a methodology which will be talking today, is not something which is just a review like we were having in the past. So okay, review the case notes and see it's okay, no problem, or you produce reports. So it's a kind of special report production looking at the case notes of the patient. and it is a care of the patient during that admission. It's not like previous admissions. For example, if patient has been admitted in the past for few times, so that's not included in that. So it's when the patient died, is only that admission, whether it is 1 day admission or whether it is 1 year admission or 1 month. So it's that one. Previous admissions are excluded. So patients died in the community are not actually included. So patient is discharged from the hospital. If he dies at home, so they are not included in that. It is like a kind of a quick information online where you do this through DATEX. SJR review is not like a blaming or anything. It's like a kind of learning. So this methodology of reviewing case notes is called SJR, structured judgmental review. And starting this process was to actually standardize and implement within the governance and quality uh, improvement structures of hospital. That's to improve care and outcome, and also to improve the confidence of public. That was the main theme behind it. So program is linked with clinical governance. So it's knitted actually. So doing review and producing data means nothing if there is no arching. So arching is there by the clinical governance and patient safety. So originally this was commissioned by uh, Quality Improvement Academy in 2016 when all these reports came up, and it was funded only in England, not in Scotland and Wales. So it was originally 3 years contract. They said, okay, let's get this online body, which is a DATEX. It was supporting portal, and Improvement Academy was actually supporting the development of this program and piloting. Initially, it was piloted in 3 hospitals. One was Manchester Hospital, it's called University Hospital. One was London Hospital, and one in Highland in Scotland. So they it's have a very big geographical area, so they want to know whether this is helpful or what was the outcome. So after these 3 pilot studies, within 6 months data was published, and they found it that's quite good, and we can actually launch the program. And then in 2019 the program was launched. So this is called National Mortality Case Notes Review Program. So aim was to establish the rollout standardization of this method of reviewing patients throughout the country. So if you are doing here and one person is doing in other hospital, both are doing the same thing. So that was the purpose of this one, and to evaluate the care of the patient who had died in the hospital, and what has contributed in patient's death, and what we can actually learn from it. Previously review was done, but those review was done totally differently. So there was like a root cause analysis type of things. So this work was designed to generate data. So it was like a data generation from different hospitals, different trusts. So we know that lots of people dying in the hospital. We can't actually do case review for each patient, SGR for every patient. So there is a criteria set who we can actually do SGR and who we cannot actually. Any patients who are having learning difficulty, they must be reviewed, who had died in the hospital. Any patient who had generated a complaint and who had died in the hospital need SJR. Any patient who had a generated a DATEX. These are basic criteria, and then over and above there will be 10% randomly chosen patients. So the hospital lead, mortality lead, actually chooses 10% of patients without any complaint or problems. These hospital safety and risk management assign these ones. Better to discuss the patient in the mortality and then do SJR. So must, but I'm saying it's better, but
Okay.
you can do SJR before as well if you are pretty sure that everything is fine. But if there is a point to discuss and you need to learn things. And there is a, for example, patient has fallen in the hospital and he had a fractured in the skull, and CT was not done and he died before that. So we need to discuss these things, and we better to just wait for the mortality before doing. So initially it was a standalone program, as you know. So this more recently it was incorporated into mortality for everywhere. So in 2019 it was incorporated. That's the time where we started training people, so you that the initial pilot project was in three hospitals, St George's and Scotland and here, and Datex was involved in that. This is WebEx basically. These are their portals. So platform is Datex. So whenever we do SJR, we have to do online, and it is Datex here. And for once you are trained, after 2 years, 3 years, you can have a retraining or revalidations with the new information, or there is a continuous education, or maybe your feedback. So there is this platform actually is there, where you can actually send your feedback as well, and to monitor your things. Now, now let's come to the core of the matter, which is actually basically what we have to do on every day. So this is called structured judgmental review. So nationality case notes review is a review process, and this is the methodology. So methodology is the structured judgmental review. So it actually incorporates three things. One is structure, so it's a very structured one. Number two is a process. So there's a process involved how we do it. And number three, data. So we churn a data out of it. So it's a numerical data, and also qualitative data is coming out of it, and it produces a theme, because there will be thousands or millions of deaths. So how we actually will come to know quickly which hospital is having problem, and which place or area of specialty is having problems. So these numbers will actually give them the idea where to actually look for problems. So that's the structure. So now the mortality review context, this is the context. I'm just giving you the case record review program in a place to assist acute care hospitals in England and Scotland to review the safety and quality of patients of adult deaths. So it has, when it started, originally it started only in Scotland and England, not in Wales. So SJR provides both quantitative and qualitative data to look at it. And what we are looking at is what has gone wrong, and what was good and what was not very good. So both are evaluated. What is the role of judgmental review? So this is like a individual cases, so we know, because when we do individual cases, and who is actually groups, and where this was actually done and why, and whether the care was good or care was not good, and also it is arched with a governance process. So it's a robust governance process on top of it. At the end, they look at it and even they can actually look under whom this patient was and which department, and even if there is different hospitals involved, so they can actually see different hospitals, and also they can actually see different departments of the same hospital. Now, clinical governance is very much incorporated into this, and it is SGR process without clinical governance is baseless. That's why clinical governance is very, very important. So what is looking is the health care processes in the patient and high risk. Um, uh, for example, any patients who is having high risk, or identification of aspects of poor care as well. And when and even it can highlight individual clinicians. For example, if we are actually clicking a button to look for under whom this patient was initially. So, for example, if the same problem is coming, so we can actually pinpoint those clinical practices or careless or reckless behavior. So this is how this can be helpful. So what is the special about it? So why we actually doing it? So why not doing the same review process which we were doing in the past? Because across in America, we know that review process is being done, and it's done very nicely for last 40 50 years actually. So this is a holistic look at the, it's not like a specialized care, but also care about nursing care and discussion about the death and end of life care, for example, or interventional care, or also we give scores to each care. So each care is being scored, so we know after 1 2 3 4 5. So I will let you know how we actually score this. And there could be second stage review as well, but second stage review is not necessary, because the studies have shown that if one review is done in one place, so the second review usually will be done at another place. It will be very similar. So that's the um, a brief introductory overview, and why and who is being done and where. So for example, from top to bottom, how this hierarchy is being organized. Now coming to the phases of care. Now this is the structure. So there are actually, they have divided the care of admission of this into hospital into five um, different phases. So phase one is the first 24 hour, and second one is the perioperative. So anything happening during the operation, if patient has undergone any procedure, for example, procedure could be bigger one like abdominal operation, or maybe smaller one like, for example, chest drains, or maybe some like abdominal drain. So this all comes under perioperative care. And the third one is the ongoing care. So the ongoing care starts from 24 hours, and it goes until the end when the patient dies. So it doesn't mean that exactly from 24 hours, but somehow similar, first 24 hours, and second phase is perioperative, and the third one is the rest of it. And then end of life care, like for example, you know at discharge care. It's not discharge care. Discharge care mean end of life care discussion with the family, and whether DNAR was done or no. And the last one is overall care. So overall care is holistically from start to end. So it's overall. So if you count them, these are five phases: 1 2 3 4 5. So these are the phases. So they divided the admission of the hospital. If patient is admitted only for 1 hour, so it will be only first phase. So if patient is admitted, for example, for a 1 month, so first after first 24 hours, so it will be next 1 month will be third phase. So this is how five phases came into. So and each phase is then given scores. So these are care scores. So one is actually very poor care, then poor care, then 5 is excellent care, 4 is good care, and 3 is adequate. 3 is in the middle. So adequate care is adequate care. Majority of patients will be good care, and some will be excellent care, and there will be some, for example, not so good. So those ones they want to identify where the um, governance process will kick in. So these are the judgmental review examples which Royal College have actually just given for us to understand how we actually write. So they want two things. One is to give the numbers to each phase, and the second one to explicitly mention why it is so good or so bad. So this is a commentary. So comments has to be included with each phase. So for example, if first 24-hour phase, we have to add a comment. Second phase, we have to add a comment. Give the number, add a comment. The fourth phase, and then add a number, and then give the comment. So comment is on one side and numbers on the one side, and the phases, five phases, 5 points, and then comments. Comments is integral part of it. So we have to explicitly mention. For example, sometimes we don't mention, okay, for example, this reviewer, this is taken from the real comments actually. So reviewer have a tendency not to be explicit, but rather to imply, for example, okay, well looked after on the whole. It doesn't mean much actually. So we have to explicitly write why it is good actually. What was the point? The second example they have mentioned is no arterial blood gas analysis done, you know, and patient was hypoxic. This does not answer. So it doesn't answer the next question. What you want to tell. So he has to mention very clearly that because of this, the arterial blood gas was not done and patient was in need of it. So is it explicitly mentioning the reason? For example, in another one, he has written, another review has written, is taken verbatim from there. A subsequent reader, such as a member of the mortality review group, has he has to impute what the reviewer was trying to say. Is it helpful for governance people? Probably not. So they wanted it more explicit. For example, sometimes we say I'm instead of saying I'm thirsty, I can say I feel dry. So the people who are listening, he may not understand actually what I want to tell them actually. So it's better to tell them explicitly that this is the reason why I'm putting this score. For example, if have put score 2, so explicitly mention that this is the reason I'm putting this score to this one. So these few examples more to just understand what actually is mentioned. So it has to be clear, concise admission note. So this is a comment from judge, from a judge who is actually is a reviewer. So he's mentioned clear, concise admission notes. So this is early senior review, appropriate initial investigation, only lacking in consideration of gravity of the situation should have been made clear in the notes and with the patient and family. So he has given 5. So why 5 when he is actually 5 is excellent, but he is actually putting that it is not actually so good because it has to be discussed with the family. And now coming to the B, although patient discussed with the consultant once, SJR once for 4 days only seen by the junior doctors. This is completely unsatisfactory. So the judgment was 2. So that's appropriate actually because 2 is poor. So the third example is good discussion with family and patient towards the end of the life, a useful comment. So is a comment was quite useful by the people who actually read them. So another example of this commentary, continued omission to provide oxygen and respiratory support. Team still failed to discuss the patient diagnosis with the patient. Referral to ITU was too late. Some useful explicit word and phrases here. So it's given an example of good comments. So the B1 is that there was some evidence of good management by overnight team with prompt review and intervention. A good comment, though he has actually given comment like a 2, like 2. So the overall there was some evidence, good management by the overnight team. And then few comments to go more. In section reviewer comments on whether specific types of problems were identified or no, whether harm was caused by that or no. So when we do review, when we do review of a dead person, we always think there is something wrong going on. So this is a bias actually. So this was study done earlier, in a and it was published 10 years ago. At that time, they've actually grouped two groups of doctors, anesthetists, 112 anesthetists. They were judged appropriateness of the care of 21 cases. So they given notes to each one, but they changed the outcome. So when the outcome was changed, then their opinion also changed in some. So, for example, in 15 cases, appropriateness of care rating decreased by 30%, 31% when the outcome changed from temporary to permanent. For example, patient has, he was asked, the patient has lost a limb because of this. And then on the other case, they said, okay, patient has died. So this was like a more severe outcome. So when the outcome was severe, their opinion changed. So that's called human bias. So there is always a human bias when we think that we are actually reviewing a patient who had died. So how to come over it? So this was highlighted in the outcome of data when the pilot study was published. So that said, we have to keep this one in mind anyway. But majority of doctors, they have been doing quite nicely, and reviewers were doing almost equivalent in everywhere, in England, in Scotland, in here, and also the junior doctors are also very good reviewers, especially the doctors in training. So this is the selection criteria. In most cases, less done is better. So there are hospital policies surrounding these selection criteria. For a service review, 40 to 50 cases will cause a significant workload for any hospital or any place. So when there is something gone wrong, we have a duty of condor to be filled up as well. And the medical examiner, we have now appointed a medical examiner in our hospital. They were not there before. Now they look at the process of certification as well. So their role and responsibility is to look at the cause of death. And if the cause of death is unclear, then the medical examiner will ask. So, whether we have done anything further to establish the cause of death, whether we have actually asked the coroners, or whether we have asked more post-mortem. In oncology, post-mortem is very rare because we know cause is mostly the cancer, but in other places like in maternity and in acute medicine, the post-mortem is quite important to find the cause of mortality if it is obscure. If it is very clear and we have CT scan and patient had a stroke and he had died, so we know very clearly that this is the cause of the death. But sometimes a patient dies in circumstances where it is suspicious, or maybe we suspect there is a poisoning, or maybe it's is assault, or maybe a cause of death is not very clear. Then obviously medical examiner role comes in. In majority of places in other parts of the world, they are basically pathologists, but they just look at the notes, and they look at the patient, talk to the family, talk to the relatives, and then talk to the treating doctor, and they come they conclude that's fine, I agree with the cause of death, and that that certificate is right. If they suspect that no, doctor has written something and I suspect something else, then they will ask us or to change it or to discuss it in our mortality, or they will ask us to discuss with other colleagues to learn about this case, or we have to initiate this the postmortem. So this is the role of medical examiner, and they are knitted together with SJR actually, because majority of them are trained with SJR review as well. See, mortality screening takes place in an identify potential learning from deaths. It's not to actually blame anyone. So it's just to know how we actually can learn um, next time. So if such cases are identified, then the medical examination will determine whether a full case note review is needed or no. Because medical examiner can also generate a request for SGR. Our job, because majority of time they will say, okay, it's fine, but obviously there are some ongoing complaints from relatives, from husbands, wife, or daughter or son, or maybe some public from public side, or maybe some colleagues. So if there is already a complaint, so then it will help them in answering uh, their concerns. Now, choosing case. So, how we choose the case for SGR? So, it's a possible concern, as I have already, it's a concern could be from anywhere, and bereaved families, staff, they have actually raised the concern. Now, all deaths, particularly diagnosis or treatment groups with an alarm has been raised. Look, for example, anybody has raised an alarm, so this death was suspicious. That's one. So all deaths in an area where the people are not expected to die, for example, relevant. These are general guidelines from Royal College of Physicians, but we have in our hospital specific guidelines which patient to review for SGR or no. That's where the learning will inform the provider that's a planned improvement work or management sepsis end of life care. There's already patient was admitted, for example, a patient is not admitted acutely, patient admitted for a planned procedure could be like a blood transfusion, for example, a patient admitted just for an infusion, dextrose infusion, and he died. So that is where we need to initiate SGR. All such patients who had admitted for a planned procedure or a planned management, there we need to initiate SGR. And now, for review results, how we actually get the outcome. For example, our job and reviewer job is just to put the data. We just click and write few things on it, and it just goes somewhere in a black hole, and where it goes actually. So where the care scores are actually putting together, and it identifies the patterns which is divided into phases of care. First 24-hour, like for example, patient is divided into five pieces, and then patient is not patient, hospital is divided into different departments, and the doctors are there who is under whom his patient is admitted, and also there are different hospital in the country and cities in the country, so all will be putting in a one place. So where we get the contrast, and we get where is the poor care happening? Is it happening in the palliative care, or is it happening in the oncology, and which consultant under whom person and which hospital is performing good? So that's how this DATEX comes about. When somebody looks at it, we are not able to look at it. Obviously the governance people will be looking at it, but today I will show you what they look at it. So they look at it this one. For example, this is a care score data sheet of 50 patients. So it is divided into care scores, initial management, continuing care, end of life care, and care overall. So when you click a button, so this is a 50 cases, it's not one case, it's a 50 cases, and 50 cases are admitted in different places, one in oncology, two there, five there, three there. So when you click one, if you want to know where is the poor care, so you click the button on poor care, so it will tell you, okay, the poor care was at the end of life. Put another button and you will know, okay, poor care was end of life and in the oncology. And if you put another button, they will like, okay, poor care was under so and so doctor, and that all the patients were admitted under this doctor, and there was a poor care for end of life. So they can actually pinpoint each and every, like a hospital, they can pinpoint by looking at the data. It's not done by them, it's done by the computer. Basically is a computer program problem, and where to look for. If there is a poor care continuously shining on one place, then obviously they will come up, and they will come up and look at it further and see how we can actually resolve the issue, and what is the issue, where is the problem. This is how this scores will stand out in a graph, or columns, for example. So we know that the excellent care is blue, you know and the other ones are poor. So looking at, immediately we will know where is the poor score, where is the excellent score, and where is the normal good score, and where is the adequate one. So you will immediately know end of life care, there is a poor care. And you will, when you play around with the computer, you will know actually which hospital. If, for example, if it is a data for whole country, and if it's a data for one hospital, then you will know which you will yeah, which department.
Yeah.
And even they can actually look at it, which consultant, actually which under whom consultant, if he's only shining one place and one per person, so they will know. So that's the beauty of this data actually. And when we put the comments on it, so comments will be highlighted like this in a computer. So majority are good, and some are actually good documented, good practice, good plan, patient, medical. So this is a cloud, like a care scores into 3, 4. This is all a real example of 50 cases. So that's how SJR is knitted with us, and with the
Mortality. And thank you very much for attending structured judgmental review training.